So thank you so much for having me today. This is going to be one of 5 cardiology talks, and we'll start off with ischemic heart disease. So today we'll be talking about stable angina pectoris, acute coronary syndrome, complications of acute coronary syndrome, and evaluation of undiagnosed chest pain. So we'll start with a question. This is a 72-year-old man who reports a 3-month history of stable exertional chest pain. Exercise ECG shows 1.5 millimeter ST segment depressions in leads 2, 3, and AVF, and the patient develops chest pressure during testing, and a Duke treadmill score is negative 11.5. Which of the following is the most appropriate management? A, cardiac catheterization, B, clopidogrel, C, stress myocardial perfusion imaging, or D, subcutaneous low molecular weight heparin? So great, the majority of you got it correct. The answer is A, cardiac catheterization. So this patient should undergo cardiac cath for definitive diagnosis of coronary artery disease, possibly followed by revascularization therapy. Stable angina is defined as reproducible angina of at least 2 months duration that is precipitated by exertional or emotional stress and has not appreciably worsened. Baseline resting ECG is required to rule out ongoing ischemia and to guide the choice of stress test. Stress testing is most useful in patients with an intermediate probability, so 10 to 90% of coronary artery disease. However, even when the pretest probability of coronary disease is high, stress testing may provide prognostic information. Results of this patient's exercise ECG stress test are consistent with the presence of coronary artery disease, and his Duke treadmill score of negative 11.5 indicates the likely presence of high-risk disease. An exercise ECG stress test is considered diagnostic of obstructive coronary disease if there is at least 1 millimeter ST segment depressions in 2 contiguous leads, and a positive treadmill study result can also risk stratify obstructive coronary disease. A Duke treadmill score less than a negative 11 are considered high risk, and scores greater than 5 are considered low risk. Patients with high-risk scores are likely to have left main or proximal left anterior descending artery disease. Clopidogrel and low molecular weight heparin are both appropriate therapies for NSTEMI or unstable angina. Although the patient has ischemia on exertion, he does not have evidence of unstable angina or persistent chest pain. Therefore, treatment with either medication is not indicated. And finally, stress tests with imaging, such as myocardial perfusion imaging or stress echocardiography, are also first-line tests that may be helpful in diagnosing coronary artery disease. The choice of initial tests depends on patient characteristics, such as age, baseline ECG, ability to exercise, and local test availability and expertise. This patient's high-risk ECG stress test results already indicate a high likelihood of high-risk coronary disease, and performing imaging would not alter that likelihood or preclude the need for a cardiac catheterization. So stable angina pectoris. So really, fundamentally, the pathophysiology of stable angina is a supply-demand mismatch for myocardial oxygen. So things that raise your myocardial oxygen demand or increase myocardial wall tension, increase myocardial contractility or an elevated heart rate, and things that decrease the myocardial oxygen supply are a decrease in the coronary artery diameter, so progressive coronary stenotic lesions, decrease in the perfusion pressure, so for instance, patients with really high cardiac filling pressures, an elevated heart rate, and a low hemoglobin. And when evaluating patients with angina, it's always important to keep in mind things that mimic angina, and this includes conditions like heart failure, aortic stenosis, reflux, asthma, pulmonary hypertension, and hypertrophic cardiomyopathy. So testing. So initial testing for stable angina includes a baseline ECG. And then for those intermediate risk patients, so patients where the probability of coronary disease is somewhere in the 10 to 90% range, you want to do some kind of non-invasive evaluation for ischemic disease. So in patients who are over the age of 65 or more obstructive coronary artery disease is suspected, stress testing is typically our first step. And in patients who are less than 65 or less obstructive coronary disease is suspected, you can consider a coronary CTA. And the big reason is patients with lots of coronary artery calcification this decreases the sensitivity of the coronary CTA, which is why we typically recommend it in younger patients who tend to have less arterial calcification. So there are a lot of options for stress testing that we'll walk through, and this really depends on the patient characteristics. So for patients who are able to exercise and have normal or non-specific changes on a baseline ECG, including a complete right bundle branch block, options for first-line testing include an exercise ECG stress test, exercise echocardiography, and exercise perfusion imaging. Exercise testing is really our gold standard, and we recommend it whenever possible because exercise capacity gives you a lot of prognostic information, and also you get the additional information of heart rate response, blood pressure response, arrhythmias caused during exercise, so there's a lot of additional information you get out of the test. In patients who are able to exercise but have had previous myocardial revascularization, have a pre-excitation pattern on their ECG, have a baseline ST depressions over 1 millimeter, who are taking digoxin or have left ventricular hypertrophy, we recommend some type of imaging along with the testing, so an exercise perfusion imaging or exercise echocardiography. For patients who are able to exercise but have a left bundle branch block or a ventricular paced rhythm, we recommend vasodilator perfusion imaging. And this is because any test that speeds up the heart rate, like an exercise test or a dobutamine stress echo, in the presence of a bundle branch block or paced rhythm makes the test harder to interpret and decreases the sensitivity. So we would recommend a vasodilator perfusion imaging. And then in patients who are unable to exercise, we recommend vasodilator perfusion imaging, dobutamine echocardiography, or stress cardiac MRI. So there are three real pillars to guideline-directed medical therapy for stable angina: risk factor modification, cardioprotective medications, and antianginal therapies. For risk factor modification, we recommend tobacco cessation, daily aerobic exercise, a blood pressure goal of less than 130/80, glycemic control, and then weight loss if the patient is overweight. For cardioprotective medications, we recommend low-dose aspirin or clopidogrel if the patient is intolerant to aspirin, and this is really to prevent blood clot formation and prevent acute coronary syndrome. We then recommend either a high-intensity statin therapy or a moderate intensity statin therapy if the patient is over the age of 75 or has had an intolerance to a high intensity statin. And this is to prevent the progression of atherosclerotic plaques. ACE inhibitors should be used in patients with diabetes, chronic kidney disease, left ventricular systolic dysfunction with an ejection fraction of less than or equal to 40%, or a history of myocardial infarction. Beta blockers can be used with a goal resting heart rate of 55 to 60 beats per minute. And then we recommend beta-1 selective agents in patients with significant lung disease. Calcium channel blockers can be used if beta blockers are either not adequate to control the anginal symptoms, are not tolerated, or are contraindicated. And we generally avoid nifedipine and other short-acting calcium channel blockers. Nitrates can be used in different forms, so we use short-acting nitrates like sublingual nitroglycerin for acute pain relief, and then long-acting nitrates to help reduce anginal episodes. And it's really important that patients need a 12-hour nitrate-free period, which is why we don't dose the medications twice a day or every 12 hours. We dose it once a day. Contraindications include phosphodiesterase 5 inhibitor use, severe aortic stenosis, and patients with hypertrophic cardiomyopathy. And then finally, ranolazine helps decrease angina and improves exercise capacity. And then there are these newer therapies such as SGLT2 inhibitors or GLP-1 agonists that we recommend in patients with diabetes. They've been shown to reduce the rates of acute myocardial infarction, stroke, and cardiovascular death. And the benefits are really independent of just the glucose reduction that you get. So for our next question, this is a 63-year-old man who is evaluated for activity-limiting angina, which is being treated with optimal guideline-directed medical therapy, including a beta blocker. He has type 2 diabetes, blood pressure is 112/72, heart rate is 60. Angiogram reveals multivessel disease with involvement of the proximal LAD. The left ventricular ejection fraction is 50%. Which of the following is the most appropriate management? A, CABG. B, change the beta blocker to a calcium channel blocker. C, multivessel PCI. Or D, a myocardial viability scan. So great job. The right answer is A, CABG. The most appropriate management of this patient is CABG. He has type 2 diabetes and multivessel coronary disease with moderate to severe symptoms despite optimal medical therapy. Compared with PCI, performing a CABG as the initial revascularization strategy in patients with a clear indication is associated with improved outcomes, including reduced rates of death, myocardial infarction, and stroke. The FREEDOM trial evaluating management of multivessel coronary disease in patients with diabetes showed that the composite endpoint of death, MI, and stroke was significantly lower in patients treated with CABG versus PCI. This difference was driven by a statistically significant reduction in the occurrence of death and MI in CABG patients, although stroke rates were higher in the CABG group than the PCI group. CABG is recommended for patients who have specific indications including left main disease, triple vessel disease, multivessel disease with a concomitant reduced systolic function, or multivessel disease with LAD involvement in patients with diabetes. Calcium channel blockers are a reasonable second-line therapy in patients who are intolerant of beta blockers or who have continued symptoms on beta blockers and nitrates. However, it would not be appropriate to switch the patient to a calcium channel blocker in this patient who is currently tolerating beta blocker therapy. And then myocardial viability testing may demonstrate hypoperfused regions of the heart that might have functional improvement if revascularization is performed. However, studies have failed to demonstrate a relationship between the results of viability imaging and the effectiveness of bypass surgery. Therefore, in this patient who remains symptomatic despite optimal medical therapy and is a reasonable surgical candidate, revascularization is indicated, and myocardial perfusion testing would not contribute significant information regarding medical decision-making. So what are the indications for coronary revascularization? They include angina refractory to medical therapy, large areas of reversible ischemic myocardium, high-risk criteria on stress testing, significant coronary disease with a reduced left ventricular function, and a left main stenosis or equivalent. It's important to remember that PCI offers no mortality benefit over medical therapy, and that CABG is primarily indicated for left main stenosis, three-vessel disease, multivessel disease with LAD involvement in patients with diabetes, and multivessel disease with left ventricular dysfunction. So for our third question, this is a 78-year-old man who is evaluated in the emergency department for 13 hours of chest pain. Troponin I is elevated. ECG shows 2 millimeter ST segment elevation in leads V1 through V4 and 1 millimeter ST segment depression in leads 2 and 3. Emergent cardiac catheterization shows severe stenosis of the proximal left anterior descending artery. Which of the following is the most appropriate treatment? A, CABG, B, intracoronary thrombolytic therapy, C, medical therapy, Or D, primary PCI? So nice job. So the correct answer is D, primary PCI. PCI is the preferred reperfusion strategy in patients with ST elevation myocardial infarction and STEMIs of less than 12-hour duration. He is being evaluated 13 hours after STEMI onset with clinical and ECG evidence of ongoing ischemia. In late-presenting STEMIs, primary PCI for reperfusion is recommended if the patient has continuing symptoms or if there is hemodynamic or electrical instability. Emergent CABG is not a routine method of revascularization in patients with a STEMI. Urgent CABG or mechanical circulatory support is indicated in patients with STEMI and coronary anatomy not amenable to PCI who have high-risk features such as refractory ischemia or cardiogenic shock. Logistical issues, including performing cardiac catheterization, having access to an operating room, assembling a surgical team, and performing surgery within the time frame needed to salvage the greatest amount of myocardium. Thrombolytic therapy has no clear benefit for patients with STEMI more than 12 hours from symptom onset. Patients best suited for thrombolytic therapy are those who present early after symptom onset and with a low bleeding risk. However, PCI is always preferred if the patient is in a PCI-capable facility and the procedure is performed as soon as possible, or if the patient can be transferred from an index hospital to a PCI-capable center quickly. And the time from first medical contact to primary PCI, the goal is within 120 minutes. If indicated, thrombolytic therapy is given intravenously, not by an intracoronary route. And finally, compared with medical therapy alone, coronary reperfusion either through PCI or thrombolysis improves outcomes in nearly all patients with an acute STEMI if performed in a timely fashion. Regardless of whether reperfusion is performed, patients with STEMI benefit from treatment with antithrombotic therapy, including dual antiplatelet therapy with aspirin plus a P2Y12 inhibitor and anticoagulation therapy. So now we'll talk about acute coronary syndrome. So acute coronary syndrome is classified as acute onset substernal chest pain, and patients can present with atypical symptoms, and this is more common in women, patients with diabetes, and elderly patients. And symptoms can include dyspnea, lightheadedness, isolated jaw or left arm pain, nausea and epigastric pain, diaphoresis, and weakness. And it's important to remember that acute coronary syndrome is a spectrum of disease, starting at unstable angina, progressing to NSTEMI, and then progressing to a STEMI. So in patients with unstable angina, they have normal cardiac biomarkers, and they may have some nonspecific ECG changes, so either ST segment depression or T-wave inversion. Patients with an NSTEMI have positive biomarkers without ST elevations or ST elevation equivalents. And then patients with a STEMI have positive biomarkers and then ST elevations of at least 1 millimeter in 2 or more contiguous leads except for V2 to V3. ST elevation in leads V2 to V3 for men is significant if they're less than 40, if the ST elevations are greater than or equal to 2.5 millimeters. If they're at least 40 years old, the ST elevations in V2 to V3 are significant if they're greater than or equal to just 2 millimeters. And in women, the ST elevations are significant if they're greater than or equal to 1.5 millimeters. And then it's important to remember the ST elevation equivalents, including a new left bundle branch block or a posterior MI where you have tall R waves and ST depressions in leads V1 to V3. And so this ECG is showing an example of a patient with an anterolateral STEMI. So you see ST elevations in leads V2 to V6. So initial medical treatment in acute coronary syndrome includes aspirin and a P2Y12 inhibitor. Oxygen therapy, if a patient's oxygen saturation is less than 90 to 92%, and then anticoagulants. And there are many different options, including unfractionated heparin, low molecular weight heparin, bivalirudin, or fondaparinux. We typically recommend beta blockade as well, and we usually start with metoprolol. Contraindications to beta blocker therapy would include cocaine-induced vasospasm, decompensated heart failure because of the risk of triggering cardiogenic shock, high-grade AV block because of the risk of worsening that AV block and bradycardia, and then patients with severe bronchospasm. We recommend nitroglycerin as the first-line treatment for ongoing chest pain, except for patients with an inferior or posterior infarction because of the risk of RV dysfunction and hypotension, aortic stenosis, obstructive hypertrophic cardiomyopathy, and very important recent PDE5 inhibitor use. And then we also recommend a high-intensity statin. So reperfusion therapy for STEMI, PCI is preferred, ideally within 12 hours of symptom onset. We do consider a delayed PCI, so patients presenting after 12 hours of symptom onset if there is sign of ongoing ischemia. If PCI is not available at the center, we recommend transfer to a center capable of PCI if the time from first medical contact to PCI is less than or equal to 120 minutes. And then we recommend thrombolytic therapy for patients presenting within 12 hours of symptom onset and the time from first medical contact to a PCI-capable center PCI is greater than 120 minutes. And then we do recommend transfer to a PCI-capable facility soon after thrombolysis. And then here they're just showing an acute, they're showing a coronary angiogram where we inject contrast via a catheter, and then there is an 85 to 90% occlusion of the mid-right coronary artery. For thrombolytic therapy, we recommend it if PCI is not available within the recommended time window. We recommend only giving thrombolytics within 12 hours of symptom onset, and then the common absolute contraindications to thrombolytics include a previous intracranial hemorrhage, ischemic stroke, head or facial trauma within 3 months, major surgery within the past 3 weeks or recent internal bleeding, and then a presenting blood pressure of greater than 180 over 110. We do use the TIMI risk score to help us estimate the risk of complications and helps guide therapy in patients with non-ST elevation MI. If patients are high risk, we recommend early revascularization, and if they're low risk, you can consider ischemia-guided therapy. So for our next question, we have a 58-year-old man who's ready for hospital discharge following NSTEMI treated with PCI and stent placement. Medications are aspirin, ticagrelor, metoprolol, lisinopril, atorvastatin, and sublingual nitroglycerin as needed. Exam is normal with a heart rate of 58, and the left ventricular ejection fraction is normal. Which of the following medication changes is indicated? A, add diltiazem. B, discontinue ticagrelor and start clopidogrel. C, start eplerenone. Or D, no changes to his medications. Great, so the correct answer is D, no changes to his medications. Oral beta blockers should be given to all patients with acute coronary syndrome without a contraindication such as decompensated heart failure, advanced AV block, or severe reactive airway disease and continued indefinitely. Calcium channel blockers, with the exception of nifedipine, can be used in patients with angina and contraindications to beta blockers or those with continued angina despite optimal doses of beta blockers and nitrates. This patient has no indications for a calcium channel blocker such as diltiazem. There is no evidence to support a change from ticagrelor to clopidogrel after PCI for ACS. In the PLATO trial, the use of ticagrelor was associated with a 1.9% absolute risk reduction in the occurrence of cardiovascular death, MI, and stroke when compared with clopidogrel. ACC/AHA guidelines note that in patients with ACS treated with dual antiplatelet therapy after coronary stent implantation, it is reasonable to use ticagrelor in preference to clopidogrel for maintenance of P2Y12 inhibitor therapy. A P2Y12 inhibitor should be continued for at least 1 year after MI. In this patient with an acute coronary syndrome and preserved LV function, there is no evidence to support the use of an aldosterone antagonist such as eplerenone. ACC/AHA guidelines recommend administration of an aldosterone antagonist to all patients with NSTEMI who are receiving an ACE inhibitor and beta blocker, have a left ventricular ejection fraction of less than or equal to 40%, and have heart failure or diabetes. ACE inhibitors inhibit post-infarction remodeling, helping to preserve ventricular function. ACE inhibitors should be continued indefinitely in patients with left ventricular systolic dysfunction and may be beneficial in patients with preserved LV function, especially in those with diabetes. An ARB can be substituted in patients with intolerance to ACE inhibitors. Similarly, high-intensity statin therapy, such as with the atorvastatin, should be continued indefinitely. So to summarize, our long-term medical therapy for acute coronary syndrome that should begin during hospitalization includes a statin, which will be continued indefinitely, aspirin to be continued indefinitely, a platelet P2Y12 receptor inhibitor, such as ticagrelor, prasugrel, only if the patient has had a PCI, or clopidogrel, and these should be continued for 1 year after an acute coronary event. The medications to begin at or before discharge also include a beta blocker, which should be continued for at least 3 years, an ACE inhibitor to be continued indefinitely for patients with a left ventricular ejection fraction of less than or equal to 40%, diabetes, hypertension, or CKD, and an ARB can be used if a patient is intolerant to an ACE inhibitor. And then spironolactone or eplerenone, our aldosterone antagonists, should be used if a patient has already been started on an ACE inhibitor and beta blocker and has a left ventricular ejection fraction of less than or equal to 40%, heart failure, or diabetes. ICD indications after acute coronary syndrome include patients that have the following 3 criteria. It's been 40 days since the MI or over 3 months since revascularization by PCI or CABG. The ejection fraction has remained persistently low at less than or equal to 35%, and the patient is already receiving optimal medical therapy for heart failure. And again, it's important that the patient meets all 3 of these conditions. And then indications for post-MI repeat catheterization include post-infarction angina and then an abnormal post-MI stress test result. For our next question, we have a 56-year-old man reporting 3 hours of chest pain. Blood pressure is 90/60, pulse rate is 110, physical exam shows jugular venous distension, no murmur, and clear lungs. And an ECG shows 2 millimeter ST segment elevations in lead 2, 3, and AVF, and 0.5 millimeter ST segment elevation in lead V1. Which of the following is the most likely diagnosis? A, acute severe mitral regurgitation. B, left ventricular free wall rupture. C, right ventricular infarction. Or D, ventricular septal rupture. So the answer is C, right ventricular infarction. In the setting of an inferior wall STEMI, the clinical triad of hypotension, clear lung fills, and jugular venous distension suggests a right ventricular infarction. Right ventricular infarction occurs in approximately 20% of patients with an inferior wall STEMI. The diagnosis can be made by right-sided ECG, which will show ST segment elevation in leads V3 and V4. Treatment consists of aggressive volume resuscitation to optimize right ventricular filling pressures, so optimizing the patient's preload, IV vasopressors if hypotension persists, and urgent coronary revascularization. Acute severe mitral regurgitation may occur in the setting of acute MI as a consequence of ischemic necrosis of a papillary muscle of the mitral subvalvular apparatus. Other causes of acute mitral regurgitation include ischemic left ventricular dilation or chordal rupture. Acute mitral regurgitation typically presents with a new widespread holosystolic murmur without a thrill and acute pulmonary edema several days after acute MI. Excessive myocardial necrosis leading to myocardial rupture generally occurs within the first week after acute MI. Mechanical complications after acute MI are very rare in the current era of primary reperfusion, but may be lethal when they occur. Cardiac tamponade from rupture of the left ventricular free wall usually leads to sudden hypotension and death. It would be unlikely for this patient to have left ventricular free wall rupture because the duration of chest pain is too short and the ECG findings of acute inferior and right ventricular STEMI readily account for this presentation. Finally, a ventricular septal rupture manifests as a new, harsh, holosystolic murmur with a palpable thrill, and respiratory distress due to acute left-to-right shunting, pulmonary overcirculation, and biventricular failure 1 to 3 days after MI onset. It is exceedingly uncommon for a patient to initially have a ventricular septal defect unless symptoms of chest pain were present for 1 to 3 days before presentation. In addition, the clear lungs on physical exam do not support the presence of pulmonary edema, which would probably be present with an acute ventricular septal rupture. So now we'll go into a little bit more detail about complications of acute coronary syndrome. So the first mechanical complication after STEMI that we'll discuss is a ventricular septal rupture. These typically occur 1 to 7 days after MI, typically in an inferior or anterior MI, and patients present with abrupt pulmonary edema or hypotension. On exam, they will have a loud holosystolic murmur and thrill. This diagnosis is made by transthoracic echocardiogram, and it's treated with an intra-aortic balloon pump, medical therapy, and surgical closure. And then this is an echocardiogram of a patient with an acute ventricular septal defect. So on this echocardiogram, so you're looking at the two ventricles at the top here, and this color flow is the flow between the two ventricles via the septum. So this is showing flow between the left and right ventricles through the interventricular septum. Next complication is the papillary muscle rupture. This typically occurs in an inferior or posterior MI, presents as a new holosystolic murmur, and patients will get sudden pulmonary edema. It's also diagnosed by transthoracic echocardiogram and is treated with urgent surgical intervention. Functional ischemic mitral regurgitation occurs in the setting of ischemic left ventricular dysfunction or dilation, and it's diagnosed by echo or cardiac catheterization and is treated with revascularization. So essentially, improving the left ventricular size and function will help improve the mitral regurgitation. Left ventricular free wall rupture occurs in the setting of an anterior MI. Patients present with sudden hypotension or cardiac death, pulseless electrical activity, and ventricular arrhythmias. It's diagnosed by transthoracic echo with cardiac tamponade, and it's treated with cardiac surgery. Right ventricular infarction, patients will have hypotension, jugular venous distension, and clear lungs. You should suspect this in patients presenting with an inferior MI, and a right-sided ECG leads will show ST segment elevations. And here, this is an ECG showing an inferior STEMI. So you see ST elevations in the inferior leads 2, 3, and AVF. The treatment of right ventricular infarction includes volume resuscitation and positive inotropes, revascularization, and avoiding nitrates, which can further decrease preload and worsen the hypotension. Left ventricular apical thrombus occurs in about 10 to 20% of patients with an anterior STEMI and is treated with anticoagulation for at least 3 months. And then cardiogenic shock is characterized by low cardiac output, low blood pressure, and evidence of end organ compromise, so either altered mental status, abnormal kidney function, or abnormal liver function tests. It's treated by emergent revascularization, and then temporary mechanical support with an intra-aortic balloon pump, left ventricular assist device, or ECMO can be used as needed. There are also multiple arrhythmias that can occur in the setting of acute coronary syndrome. Atrial fibrillation happens in about 10 to 20% of patients with the STEMI, and it's usually transient. Ventricular tachycardia and fibrillation can occur and should be treated with urgent cardioversion. Ventricular ectopy can also occur, so patients can have frequent PVCs in the setting of ischemia, and really the treatment is to treat the underlying ischemia. Accelerated idioventricular rhythms can occur. These are benign and do not require treatment with beta blockers or antiarrhythmic medications, and they're very common following reperfusion. This ECG is actually showing an accelerated idioventricular rhythm. It may be the result of an accelerated ventricular focus that generates an impulse faster than the sinus node, usually in the range of 60 to 100 beats per minute. In the setting of acute ischemia, accelerated idioventricular rhythm may be a marker of spontaneous or induced reperfusion. You can also have different types of AV block. So Mobitz type 1 block, you really only need to place a temporary pacemaker if the patient is symptomatic. And then with higher grade AV blocks such as Mobitz type 2 or complete heart block, you consider permanent pacemaker implantation if the rhythm persists after revascularization. So finally, we'll end with the evaluation of undiagnosed chest pain. So there are kind of 6 really important serious conditions that you should always think about when evaluating an individual with acute chest pain. The first is acute coronary syndrome, and again, we talked about how this is a spectrum ranging from unstable angina to a non-ST elevation MI to an ST elevation MI. Acute coronary syndrome accounts for about 12% of all causes of chest pain. Patients present with either angina at rest or new onset angina or unpredictable angina. And then we diagnose this with ECG, stress testing. Pulmonary embolism, patients will present with pleuritic chest pain, dyspnea. Sometimes they'll have a cough and may or may not have hemoptysis as well. They may or may not also have the presence of a deep vein thrombus. And then this is diagnosed by CT angiography. Pericarditis plus cardiac tamponade will present with sudden pleuritic chest pain. Patients will be tachypnic and dyspneic. They'll have marked jugular venous distension on exam, and this is diagnosed with ECG and echocardiography. Tension pneumothorax, patients will present with pleuritic chest pain, dyspnea, hypotension, and then very importantly, absent breath sounds and a deviated trachea, and this is diagnosed by chest x-ray. Aortic dissection presents with tearing chest and back pain. Patients may have unequal blood pressure and pulses in their upper extremities. They may also have a stroke or MI in the setting of an aortic dissection, and this is also diagnosed by a chest CTA. And finally, esophageal rupture. Patients, it's often develop this in the setting of repetitive vomiting, and then they'll develop acute retrosternal chest pain, and this can be diagnosed by chest x-ray or CT. And with that, we'll end with some questions from the audience. So the first question is the question of when to use spironolactone. And so talking about using spironolactone in the setting of acute coronary syndrome as opposed to the guidelines recommending it for specifically heart failure with a reduced ejection fraction. Spironolactone and other aldosterone antagonist medications have kind of 2 separate indications for use. So in the setting of acute coronary syndrome, we'll use it for patients who are already on an ACE inhibitor and a beta blocker, and then also have another diagnosis such as left ventricular systolic dysfunction, heart failure, diabetes. And then For patients with heart failure with reduced ejection fraction, even if they've never had coronary disease or an acute coronary syndrome, we do consider spironolactone for patients with ongoing symptoms despite treatment with an ACE inhibitor or beta blocker. So there's kind of the use of spironolactone in patients with and without coronary disease. So they're kind of two different categories that we're talking about. The next question is, does the 12-hour nitrate-free period for long-acting nitrates also include the PRN sublingual tablets? And that's a great question. So no, we're talking about when you're using these longer-acting nitrates, such as isosorbide mononitrate specifically. That medication is a medication that should be dosed once a day to give patients that 12-hour nitrate-free interval. So if you start a patient on a low dose of isosorbide mononitrate and you want to increase the dose, we'd recommend increasing the dose in that once a day use as opposed to increasing the dose by giving it twice daily, which sometimes happens. Certainly, we would hope that patients aren't requiring sublingual nitroglycerin, numerous times over a 24-hour period, but for the short-acting nitrates, you do not need that 12-hour nitrate free. So if you have a patient presenting with acute coronary syndrome and they develop chest pain overnight, it's okay to give them, additional doses of sublingual nitro, or if they're on an IV infusion of nitroglycerin, you don't need to give them that 12-hour break. Then there's a question of, do you anticoagulate if the patient has new atrial fibrillation after myocardial infarction, since it can be transient? And this is a great question. So typically for atrial fibrillation after MI or post-operative atrial fibrillation, the thinking has kind of changed about that. We now treat that the same in terms of anticoagulation as the same as any other diagnosis of atrial fibrillation, because what studies have shown us are that often these patients are actually having chronic episodes of atrial fibrillation that they do not feel. So we would still recommend anticoagulation based on their CHA2DS2-VASc score and bleeding risk, even though sometimes, their overall burden of atrial fibrillation may be low. So for less than 60, so this was a question about in a patient coming in with what sounds like stable angina and an intermediate risk, we were talking about options for non-invasive testing for coronary disease. In patients who are older than 65 and where you're worried about more obstructive coronary disease, we typically recommend stress testing, so what we call some kind of functional assessment. And that can be, we talked about all the different types of stress testing ranging from exercise ECG stress test to echocardiography, perfusion imaging, MRI. In patients who are less than 65 or less obstructive disease is suspected, you can do a coronary CTA. And it's important to note the difference between a left heart catheterization with a coronary angiogram and a coronary CTA. So when we send someone for a left heart catheterization, this is an invasive procedure where they go to the cath lab, there's actually a catheter placed in either their radial or femoral artery to look at the coronary arteries. For a coronary CTA, that's a non-invasive test, so it's the same way you can order a CTA protocol to look for a pulmonary embolism or aortic dissection. That can be protocol to look at the coronary arteries as well. For patients with incidental coronary calcification seen on CT who are not having angina, there's a question about the need for stress testing. So typically our recommendation is if a patient does not have any symptoms, we recommend good medical therapy for coronary disease, because typically coronary artery calcium is associated with underlying atherosclerotic disease. So we'd recommend therapy with things like aspirin or a high-intensity statin, making sure that their blood pressure and their glycemic control is all under control, but do not feel that they need a stress test unless they're having symptoms. Then there is a question about what is the care needed for patients who receive thrombolytics, and then what is the care when they go to a PCI-capable facility. So the important things to consider if you are in a center that does not have the ability to perform a PCI and you are giving thrombolytics for a STEMI, the things that you really are looking at are for bleeding complications, so bleeding at any access site, any altered mental status or mental status changes that would suggest bleeding, GI bleeding, and then you're also looking at blood pressure control because that will be really important after giving thrombolytics to reduce the risk of intracranial bleeding. And then after receiving thrombolytics, there's still a chance that patients can develop either a recurrent thrombus or restenosis or have ongoing symptoms, which is why we recommend transferring them to a PCI-capable center. In case they develop any of these things, they can then get a left heart catheterization and PCI if needed. And then great question about how we figure out pretest coronary probability before doing a stress test. And I think it was just mentioned by one of our great moderators, there are scoring systems to address this, like the Coronary Artery Disease Consortium. So essentially you're looking at kind of the quality of the symptoms that they're reporting and their various risk factors for coronary disease. There is a recommendation for when patients should have a follow-up. There's a question about a recommendation for when patients should have a follow-up echocardiogram if the first diagnosis of a left ventricular ejection fraction less than 40% was following ACS. So great question, because this comes up a lot in terms of the need for defibrillator placement for primary prevention. And we typically say that if you had an ACS, had an MI, we want that patient to be their ejection fraction to be reassessed if it was initially low 40 days after the MI. And then if you have patients who have more stable disease but underwent some type of revascularization with a PCI or CABG waiting at least 3 months. In that time, the patient should be started on guideline-directed medical therapy for heart failure, which we'll talk about in one of our next sessions. And then there was a question about whether you can do exercise ECG stress testing in patients with a right bundle branch block, and yes, you can. So you can do exercise ECG stress tests, and then you can also do exercise stress testing along with other imaging in patients who have a right bundle branch block. And then I think there is a question about the use of ACE inhibitor versus ARB. Typically, all of our guidelines recommend starting with an ACE inhibitor and only using an ARB if the patient has some kind of intolerance or allergy to the ACE inhibitor, such as cough or angioedema. And then for the P2Y12 inhibitors, any criteria to use one versus the other post-PCI? So we talked a little bit about the use of ticagrelor in patients who have had an acute coronary syndrome with PCI over clopidogrel. But for the most important thing after ACS is that all patients are on dual antiplatelet therapy. In practice, sometimes that does depend on insurance coverage and things like that. And then there's a question of when is an exercise echo preferred over exercise perfusion imaging? So that's a great question. So both tests have their strengths. Exercise echo can be very helpful if you also are worried about some kind of valvular disease or abnormality in the patient. So you get the additional information of also looking at their valves if you're sort of working up symptoms where you're not sure if they're truly from coronary disease or potentially from heart failure or valvular disease. And so if that's a question, exercise echo can be very useful. And then certainly I will consider perfusion imaging over echo if for whatever reason the patient has had, challenging images in the past. If you've gotten an echo on the patient and the report says technically difficult study or difficulty, seeing all of the walls of the heart, or if the patient has resting wall motion abnormalities, I would move to a perfusion imaging study because that will be more useful. And I think I caught all of the rest of the questions. So thank you all for your time.